I take it home too. It's pretty darn good. Hi, everybody. I know I recognize a lot of you, but my name is Debbie DeAngelo. I'm a registered nurse and I work as a holistic health coach. And on a totally unrelated note, I'm also a ballroom dance instructor. So as I try to keep warm up here, I might be doing some of my moves. Yeah, right over the cord. So actually, the name of the talk is it hot in here or is it me? Not tonight. Tonight it is not warm, which might be good for us. But obviously the talk is on menopause and perimenopause. And as a health coach, I work with a lot of women, some guys, but I'd say 80% of my clients are women. So a lot of women who are going through menopause. That might not always be why they're coming to see me, but we address that too. And I remember the story of this one woman. She was a breast cancer survivor. So she had had breast cancer. She went through her treatment. She came through it successfully. You're going back for her visits to the oncologist, talking to him. Everything's great. And she says to him, you know what, I'm really struggling. I'm having a lot of hot flashes and night sweats. I cannot sleep at night. I'm sleep deprived. My mood, like I don't feel well. You know, what can we do? And unfortunately, he said to her, well, you know what? That's something you really just kind of have to live with because it's a side effect of the breast cancer treatment that you had. And, you know, you're just going to have to tolerate it and just be glad we got the cancer and everything's okay. And so she came to me and said, what kind of life is this? She said, I'm really happy, you know, that we caught the breast cancer. And I know that this is a consequence of the treatment. She said, but I'm miserable. And she said, is this really the way I have to live? Because she said, I'm going to tell you, I never forgot this. She said, I'm going to tell you, if I had a choice between living to a long life, but being this miserable every day, or living a shorter life and having this taken care of, but my quality of life was better, she said, I picked the latter. She said, quality of life has to count for something. So the good news is, those aren't your two choices. It's not like just, you know, you should be lucky that you are alive, but you're going to be miserable every stinking day. So we have choices and we have a lot of options. And over the years, things have improved and it offers us a lot of possibilities because not everybody's the same. So what I'd like to do tonight is just talk about some of the topics that women usually struggle with or have questions about. Some of them are things that, you know, maybe we've heard or some misconceptions, or perhaps the information has changed. I always like it when people ask questions, so feel free to pop up and, you know, ask away because chances are if you have a question, somebody else does too. Before we get into that though, I kind of like to make sure we're starting on the same page and we kind of define a few terms that we normally use. So the term natural menopause, what is natural menopause? Well, when Mother Nature's allowed to continue just along her own merry way and, you know, nothing interrupts her, menopause usually occurs between the ages of 45 and 55. So that's a span, it's an age range. And that is a transition. It occurs over a period of many years. And those signs and symptoms that we can get occur years before menopause actually happens, because the word menopause means the cessation of menstruation. So your periods stop for 1 year. You don't know that until after you've gotten past the 12 months. So in a way, it's kind of a diagnosis that you make in retrospect. And, you know, we've all either heard from friends or maybe it's happened to us where you think, I'm almost at that 1 year mark. I'm 10 months in, I only have 2 more months to go, and boom, you have a period. And you got to start all over again, counting that 1 year period. But the several years before that is usually when all those changes occur and women struggle the most. And that's called perimenopause. So that's like the big term that you hear anymore, like in TV commercials and when you're reading anything about menopause, it's perimenopause. That's what that means. It's the years where a woman's experiencing things like hot flashes and night sweats, erratic periods, like heavier, lighter, longer, shorter, you skip a few, like they might be all over the board. About 80% of all women will experience the hot flashes and night sweats. To what degree? Everybody's different. Some people, they hardly know they have them. Some people, you can't even tell when they're having it. And then some other people, you look at them and you think, are they having a heart attack? Like they're really sweaty, their faces get really red, they're doing one of these, practically ripping off their clothes. So everybody, just everybody's a little different. It could be problems with vaginal dryness or decreased libido. It could be an increase in vaginal infections or urinary tract infections. There could be mood swings, kind of like that PMS kind of thing. Only with PMS, you usually know about when your period's going to occur, and that's what it times. But if your periods are all over the place and erratic, you might feel like you're having PMS every day of the month. And then other months you feel perfectly fine. And that's the thing. Every month can be different. So you might have some mood swings. And if you are predisposed to anxiety or depression, you might find that there are months where that's a little bit worse. Sometimes women will report cognitive changes, mostly attention span, level of concentration. They'll say, I just read this paragraph 3 times and I don't even know what I just read. I got to read it again. It's like it's not always sticking. And I always reassure women, you haven't suddenly become stupid. Your IQ did not drop at all. It's a little thing we call like mental pause, and again, worse in those years preceding menopause. But after your hormones start to calm down a little bit, those things generally start to return and there is some normalcy there. Some women find that their skin becomes really dry. Maybe they have achy joints, those kinds of things. So those are some of the changes that can occur. The good news is most women don't get like every one of those changes. Some women will say, oh, I never had a problem with hot flashes. And other women will say, I can't sleep to save my life. Somebody else is like, oh my God, I feel like I'm on an emotional roller coaster. So it can hit us all differently. But for women going through a natural menopause and perimenopause, it's a gradual transition. Now that we can contrast to sudden menopause. And sudden menopause is when something occurs that triggers menopause very quickly for us and at any age. So one of the most frequent causes would be a hysterectomy, especially with both of your ovaries removed. Now, it is possible that they can take one ovary and leave the other one, and a couple different things can happen. You might be perfectly fine, but 50% of all women who have one ovary removed go into menopause within 6 months of that. And they believe it's because the circulation to the other ovary has been interrupted. So it can occur, if somebody has a hysterectomy with both their ovaries removed, it can occur literally in hours. They go into surgery, they've got enough estrogen, after surgery, boom, things start to bottom out. It can be due to cancer treatments, chemotherapy, pelvic radiation, certain medications that are given for specific medical conditions can cause menopause and throw you into it. Anorexia or some eating disorders can. And then some women, they find it just runs in their family. It's called premature ovarian failure. And for whatever reason, people in their family go into menopause at an early age. But what happens there is instead of like in perimenopause, when your estrogen and progesterone levels are doing this, they're fluctuating and declining over a period of years. Theirs are typically going like this. And that's pretty rough. So normally when I'm working with somebody like that, it's not that we don't employ some of the same treatment strategies, but you usually have to be more aggressive and you have to go after it quickly, because if not, you're kind of behind the 8 ball. And that's really the truth with natural menopause too. If I have someone who comes in and says, I'm just beginning to experience this, can you tell me what I should do to try to make this an easier transition, to support myself? That is a lot, well, for them, it's going to be a lot nicer because you've got the luxury of time and you can support your body before it's struggling too much. If you try to tough it out, you try to get through it, and then you're just feeling miserable and you feel like you've hit rock bottom, and then you want to intervene, you still can, but we might have to do things a lot differently than we would have initially. So when we talk tonight, I'm going to take you through kind of the way I walk women through it, like the least invasive kinds of things, the more naturalistic things. Then we'll go right down through medication. So you've got a lot of options. Where you start in that option spectrum depends on how you're feeling and where you're at. So with suddenly menopausal women, we might start out here rather than here, like with naturally menopausal women. Okay? So those are some of the standard terms that you'll hear. One thing I would like you to know, and sometimes it's a little difficult for women, is, you can go throughout your whole life and you can kind of neglect your diet and you can neglect your own needs because you're taking care of everybody else's. And you might be able to get away with that because your body's a little bit younger, hasn't been doing that for as long, can kind of compensate. Your body's always going to try to support you. It's always going to try to function well and help you to feel better no matter what you do to it. But the older we become, the harder that is, the more difficult that is. So now you're taking a time in your life when your body's got to go through a major adjustment, because that's what it is. It's a major change. Just like when you started your period, if you can remember back that far, it's quite an adjustment. Same thing on the other end. But now, we're not teenagers. Our bodies aren't responding that way. We don't have a carefree life as most teenagers. Now we're older, we have responsibilities, there are problems, we're caretakers, like there's all kinds of things. So now your body is dealing with that and something additional. So this is the time where you really cannot afford not to take care of yourself. You have to pay attention to yourself if you want to get through that period as relatively unscathed as possible, and just supporting your body and what it's going through. And even though you might go through menopause during certain age range, the effects of it last longer. When you look at your bone health and osteoporosis, when you look at your heart health, estrogen, and to some extent progesterone and testosterone for women, but estrogen in particular is very protective for a woman. And you're always reading how a woman's risk of heart disease is lower than a man's until the age of menopause. And then after menopause, it's the same as a man. Okay, we have that cardio protection from the estrogen. It makes our blood vessels nice and elastic. It helps with our cholesterol level, helps with our blood pressure. Same thing with our bones. So just because you've gone through menopause doesn't mean there aren't things you still have to pay attention to maintain your health as a consequence of it. So taking care of yourself is really crucial at this stage. This would not be the time to skimp on sleep and overindulge in caffeine and sugar and those kinds of things, especially if you're struggling with other health issues. You're just making it harder for your body, whether it's menopause or not. It's just making it a little harder for your body. So obviously nutrition is going to be a big cornerstone of things. It supports your body. It gives your body the nutrients to manufacture the hormones, your brain chemicals, all kinds of things. When I'm talking to women about their nutrition and they're reporting to me like a little snapshot of their life, what they tend to eat every day, how they sleep, their activity level, I kind of just want that little snapshot. As I'm listening to them, I'm trying to put a few things together and I'm asking them specific questions. At the forefront of most people's minds, especially women, will be their weight. And that is important to be at a healthy weight, but I'm also trying to think about health. So as they're reporting to me, oh my God, I went through menopause and I gained weight and I can't get rid of it. I'm trying to think to myself, all right, am I hearing any symptoms that might be a thyroid problem, that might be a blood sugar problem? It could be anxiety or depression that affects your weight. It could be an eating disorder. Like those are all things that affect your weight too. And sometimes because some of those things pop up or are more prevalent midlife or beyond, we tend to equate them all with menopause. So it's not necessarily menopause, although estrogen does influence things. And one term I like to use with women is weight shifting. Okay, so honestly, when you look at the studies, weight gain during menopause is not usually something excessive, within 5 pounds or so. But weight shifting is different. So you could look at the scale and it might be about the same number, but your clothes are telling you a different story because they're not fit in the same way. Things move around, things migrate, and that is somewhat influenced by menopause, but mostly influenced by age. by things like cortisol level, which occurs especially as we become more and more stressed or we're not taking care of ourselves. So it's not always emotional stress, it's also physical stress. So you might find that, gee, where did this little jiggly pocket of fat come from? You know, it didn't come, wasn't there before, but it doesn't necessarily mean you gain weight. So things do shift around, things do change. And it depends on your body type to begin with, you know, where you tend to carry your weight. One thing that I do assess in women would be protein intake and distribution. And we're always reading where Americans have too much protein, need too much protein. I don't find that with my female clients. And if they do eat an adequate amount of protein, typically they're not getting it evenly distributed at each meal. And that's really important. So what happens with a lot of women is they tend not to eat much protein at all at breakfast. And some women are big breakfast skippers, so they don't get anything. And at lunch, they get a little bit, and then they eat all their protein at dinner. Because maybe they come home and make a meal, and it's chicken or hamburger or whatever, and that's where they get their protein. That leaves us kind of unprotected throughout the day because protein's really stimulating to your metabolism. So in order to get things going in the morning, you know, you've been asleep at night, your metabolism's slowed down, even though your body's repairing, it's slower because you're not up moving around. You don't need to have a higher metabolism unless you work third shift. I hope none of you do that. That's a tough one. But when we get up in the morning, it's kind of like a wood burning stove. Like the embers have died down and you need to stoke it up to get it going, and eating does that. So what you eat's important too. So we need some of that protein then. We need protein because the amino acids, or the building blocks of protein, are actually the building blocks of those brain chemicals, those neurotransmitters that are important for mood and mental clarity. And they're also important for a host of other functions in your body. So that's why that protein intake at regular intervals is important. You need it for your energy level. If your body has to constantly struggle to maintain an even blood sugar level, you're going to feel tired. You might feel hangry, as we all say, and you're not going to feel energized. And it's tougher because now your body's experiencing hormonal flux, and it's, you know, it's like fighting to find that equilibrium, and now you're not even eating to support it. So you're going to find that the mood swings might be worse, the cognition might be a little bit worse. So one thing I would recommend is paying attention to your protein intake. Just as a ballpark figure for most people, for most women, 15 to 20 grams at 3 meals a day. So you need to have it at each meal. And I'm not saying it has to come from meat. I'm not saying it has to come from, you know, any kind of animal sources. You can get protein from vegetable sources too, but you do need to have that protein. The other thing I look at, and we tend to overlook, is your consumption of omega-3 fatty acids. That's one of the healthy fats that we talk about. So omega-3 fatty acids are neuroprotective. Your brain needs fat in order to function. 60% of your brain cells are made from fat. So we need that. So when we're looking at mood and mental clarity, we need that there. Omega-3 fatty acids are also important for your heart. So those are the kinds, and we're going to talk about the foods in a minute, but those are the kinds of fats that increase your good cholesterol, lower your bad cholesterol and triglycerides. It's good for your skin, hair, and nails. So if you have a problem with eczema or psoriasis or dry skin or anything like that, your omega-3 fats are going to be very protective. They balance your hormones. So during menopause, that's a good thing. And they're anti-inflammatory. So they decrease inflammation in the body. Where can we get omega-3 fats? That's right, fish. Mostly cold water fish like salmon, mackerel, tuna, trout, sardines. Does anybody eat sardines? Honestly, I love them. I tried them in the can, and they're just, I feel like, who knew? I'm like, well, all right, I'll try anything, and I like seafood. And they're in olive oil. I just drain them, you know, pat them off, and they're very, very good. You can get a lot of protein, some great, one of the best sources of omega-3 fatty acids right there. Let's not think that. Nuts and nut butter. In fact, the simple old walnuts got one of the highest contents of omega-3 fatty acids. And any kind of nut or nut butter, so it's almond nut butter, peanut butter, anything like that. Your soy and flax, which we're going to talk about soon. So these products over here, the soy nuts that you had, the edamame that you had, the flaxseed, very high in omega-3 fatty acids. So it's not always animal sources. Eggs, especially if the hens have free ranged, on grass and stuff rather than being fed corn. And along those lines, greens, because that's really what the free range animals are eating, some kind of green. So greens and mangoes. We were talking about mangoes earlier. Mangoes, good sense. Yes, good source of omega-3 fatty acids. So you can get some of those. So it's not always from animal sources. There are plant sources too. So start including some of those in your diet. Now, we were just referring to soy and flax, and oftentimes women will ask me, well, should I be eating that? What do you do with it? How do I eat that? Is there anything I have to be careful of? There are foods that we call functional foods, and those are foods, which I think like every food is a functional food, like healthy food, but these are foods that we eat for specific therapeutic purposes. And soy and flax are considered functional foods, especially during menopause. A host of benefits. First of all, they help to quell menopausal symptoms. So yes, that is an option for women. I have a lot of women who start using these products, especially if they're just having mild symptoms, and find they don't have to do much else other than change their diet and use some of these. So again, it depends upon where you are in that spectrum. They are heart healthy, as we just found out with the omega-3s. So they balance hormones in sufficient amounts, and I say sufficient because it's actually been defined with soy. 25 grams of soy protein a day, along with your heart healthy diet, does improve your cholesterol level and is considered to be heart healthy. Now, when you start reading labels and you see like how much soy you have to get for 25 grams of soy protein, it depending on your source, it's quite a lot. Like if you were drinking soy milk, it's basically going to be like 3 glasses of soy milk a day. Now you saw, Shannon, what did you say is 14 grams? 14 grams. Yeah, so that's, that's like about half right there, just, yeah, but it's like half of the 25 grams right there. So you're well on your way. So it just depends on what you choose. Reduce overall risk of cancer. And we're going to talk a little bit more about cancer and soy in a minute, but yes, they're anti-inflammatory and they do reduce cancer risk. Soy, not flax, but soy does help to preserve bone density. So some really good points, in their favor. And you can see where that becomes like these foods can become a menopausal woman's friend if they've never used them before. And then you kind of look at studies in other countries where they have mostly a plant-based diet or a Mediterranean style diet. They use edamame more frequently, or they use soy products more frequently. Their transition through menopause is a lot easier and a lot different than ours. So there is actually something to that. Sure. Mm-hmm. 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 Is that correct? Not exactly. Okay, so the way that some of the herbs work and and the soy products, part of it is that they are phytohormones. So we see plant hormone and we think, oh boy, that's ding, 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 wrong, wrong, wrong. We have 3 different types of estrogen in our body: estradiol, estrione, and estrol. Estradiol is the most potent form and the one we make a lot of. It's the strongest form, okay? Estriol is the weakest, and it's one that is produced during pregnancy, and it's the highest. Remember, pregnancy and breastfeeding are protected against breast cancer. So initially, we thought, holy cow, we're flooding our system with something like estradiol, and we're significantly increasing the estrogen in a woman's body. We've now found that that is not exactly true. What happens is it works as the weak estrogen, like the estriol. And our bodies, the receptors on our cells, have more of an affinity for the weaker form, the estriol, than the estradiol. So if it has a choice, it's got all this estradiol in its body, and it's got estriol from your food, it is going to suck up the estriol first, and it attaches to those receptor sites. And now it blocks the effects of estradiol. There's no place for the estradiol to go because the receptor sites are all saturated with the estriol. So yes, it works like an estrogen, but it's the very weakest form of estrogen. So what they believe is it actually is protective like estrogen in many ways, like with your bones and your signs and symptoms, but it doesn't carry the risks that the potent estrogens carry because you only have so many receptor cells and they can't all be taken up by estradiol and estriol. So if it has more of an affinity for the estriol, you're kind of decreasing your more potent estrogen. So that's one thing. The other thing is we've also realized they don't just work at the level of the receptor cells. They actually work to influence your neurotransmitters. So a lot of the phytohormones work at the level of the brain. And when we look at some of these medical options or medicines that can be used to help with menopausal symptoms, some of them are antidepressants because they work on the neurotransmitters and they do control hot flashes and night sweats and some other signs of menopause. So there's a lot more to that story. So bottom line, what should you do if you've had breast cancer or you're high risk or you're just, nervous about it? The general consensus is that in moderation, whole foods, not soy supplements, not anything that, picks apart the components of soy and puts it in a pill, would be safe. So whole foods, meaning not junky foods like soy chips and soy snack foods and soy this, that, but your soy milk, your edamame, your soybeans, your dry roasted soy, your tofu. And for me, I would say moderation a couple times a week, not daily. So that seems to be where the organizations that kind of govern the menopause information have been for several years now. Okay, they're both plant-based. Almond milk's a little lower in protein. So you're going to get omega-3 fatty acids from it, it's almond, but lower in protein. Soy milk is closer in protein content to cow's milk. So it's the closest we have to cow's milk while being plant-based. The thing I will tell you about soy, just so I don't forget, is that you want to make sure whenever you're consuming soy, sorry, Jen, I didn't even look. Yes, it's either organic or it has non-genetically modified on there because most of the soy products in this country are genetically modified. So if it's organic, it cannot be, or if it has that little label of approval down there, that little certification, non-GMO, then that's fine. And the other thing you should know about soy is if you are taking any kind of medicine for your thyroid, you can still have soy products, but you want to separate it from your thyroid medicine by at least 2 hours so that it doesn't impair the absorption of it.
Why aren't you in the OB/GYN office?
Oh, that's funny. You know what? A lot of my menopause referrals come from the OB/GYN office.
Because I feel like there's mass support. I mean, and I'm one of those people that's been to my OB/GYN saying, I'm struggling. I'm having hard flashes. I'm losing sleep from one of those battles. I'm losing my mind. I'm losing all over the place. I was basically told, that's where you are in life.
Yeah. You know what? I really think it, and this is not making an excuse because I always feel like if something isn't your area of expertise, or if you just don't have time, and let's face it, how much face time do you get with your doctor? That you should make a referral to somebody who does know and that can help you rather than saying, I don't know, oh, there's nothing you can do. Or the worst case scenario in my mind too is when they say, oh no, that stuff doesn't work. That don't pay attention, don't use any of those supplements, they're not gonna work. That your diet stuff, you might as well forget it, it's not gonna work. So just knowing what resources to use, I think. And sometimes your best resource may be a really credible book, something that's helped you. It could be other women who've been through it who say, oh, this is what I did, or a professional. Now, flaxseed, very close to soy, has a lot of the same benefits. They don't really think that it does anything for your bone health. That would be the only difference. Very good, especially for your heart health with the fiber and the omega-3 fatty acids, helps with your menopausal symptoms, good skin, hair, and nails, all those kinds of things. Also contains something called lignans, and lignans help reduce your cancer risk. So that's where the anti-cancer effect comes in with your flaxseed. Does anybody use flax? How do you use it?
I put it in my smoothies or something.
Yeah, with flaxseed, it comes in the golden or the brown variety, and they look like teeny weeny little sesame seeds. And you need to grind them up before you use it so that it releases all the components. If not, they kind of pass through undigested. So make sure you grind it. You can use a little coffee bean grinder, a little electric, grinder, whatever you want to use. Whole seeds are good at room temperature for a year. I think I put this up. I'm going to put this on your handout. And then ground seeds are good in the fridge for 3 months. I usually just grind up like a cup and use it so it stays kind of fresh, and then use that 1 cup at a time. Love putting it in the smoothie. In fact, I gave you a recipe for a soy smoothie on your handout.
What about hemp seeds and chia seeds?
Yep, hemp seeds, still same benefits. Not the lignans, but who knows? They haven't studied those as much, but still very beneficial. Chia seeds, another beneficial one.
Put it on myself.
Mm-hmm. And chia is really good as a thickener too. So like when you're making some of those vegan puddings and stuff, or you're making something and you want to thicken it, you don't always want to add starch, the chia seeds will do the trick. No, they're pretty soft. Yeah. Mm-hmm.
That's what I do. I can just
freeze
them on myself. Eat them.
Mm-hmm. Yeah, but with the flax seeds, even though you can eat them and chew them, a lot of them just like they're so tiny, and a lot of them you don't get chewed or broken down. So they just kind of go through and digest it. If you really want all the benefits from them, make sure you grind it. Right. That's more of a marketing thing. Yeah. So we have our nutrition, we have our functional foods. Next comes supplements. Yes, I do believe in supplements, and I do find that they work for people. However, with everything else, you got to know what you're doing. You got to know which ones to choose. You shouldn't be on like a medicine cabinet full of supplements. And sometimes, when I see my clients and they walk in and I see that they've got like a grocery bag, I always know what's in there. Oh my God, they've just cleaned out all their dietary supplements, and here they are, and they've dumped them. It really shouldn't take that. I like to take a look again at the whole picture and see what somebody's got going on. And in my mind, if I can find a supplement, and usually you can, that can kill 2 birds with 1 stone, why not use that one rather than a separate one for each thing? So a small handful in the morning, a small handful in the evening is really all most people need. Which ones do I tend to go for? Well, it again depends upon what women are dealing with, but one thing that I do put most people on is a B complex, a B100 B complex. Complex means it has the whole family of B vitamins, which is about a dozen of them. 100 is the dosage of most of them. You'll find that a couple of them are different just because the RDA is different, but that's what B100 means. Why do I put women on that? Well, Bs are one of the vitamins that kind of flush out of your body on a daily basis, and they're good anti-stress vitamins. They're also good for your heart health. They're good for your brain health, and B vitamins also decrease the risk of colon cancer. Usually what women will say is, yes, I take B vitamins, I take B6, I take niacin, I take this for my hair, I take this for, whatever. But B vitamins work best all together, so they like their whole little family. And if you start taking higher doses of one and not the other one, sometimes you can cause a little bit of an imbalance. So typically I don't put somebody on just A, B, B whatever, 3, B6, whatever it is. So that's one I normally give because people are normally kind of like shorted out, tired, overwhelmed. But then there, your long-term risks too, like your heart health and just overall cancer risk. That's a good one. You can find those nowadays as a time release. That's really nice because B vitamins, as I said, they flush out of your system. They will give you bright yellow urine. That's one of the things I warn people about, is people will be distraught when they see, golden urine. And if you get a time released one, it slowly makes those B vitamins available to you throughout the day. So it's not just like, here's a bunch of B, use it or lose it, and now you're unprotected. Calcium, D, and magnesium, really big at looking at that, especially because the first 7 years, 5 to 7 years after menopause is a time of accelerated bone loss. That's how protective estrogen is to your bones. So it's not that you aren't going to lose bone past that, but the fastest time of like mass exodus of density from your bones and calcium from your bones is that first 5 to 7 years after menopause. So you really have to make sure you're getting enough, some from your diet, some from your supplement. I always ask women to get a vitamin D level if they haven't already had one, so that I can see where they're at. And then we can decide how much D they need. And what I see around here, especially in a day like today, we don't have a lot of sun all year round, and it's not always that potent. So most people do need a supplement. I always ask women to get me the number because it's usually reported as a particular digit. And often when you call the hospital or the doctor's office, they'll say, oh, it's normal, because normal is reported as like over 30. But I want to know the number because optimal is at least 50 to 80. So I try to get them up closer to that. And so I will kind of titrate and adjust their dosage based upon their vitamin D level. Calcium and magnesium are best taken as a split dose. So a little bit twice a day rather than all at once, because your body can only absorb a little over 600 milligrams of calcium at once. So if you're taking more than that, because most women will need like 1,000 or 1,200 or whatever, and you take that all at once, you're only going to absorb about part of that. So we break that up and balance that out. Magnesium is also needed for muscles, for muscle relaxation. It's excellent for your heart because your heart is a muscle. So there are many reasons beyond your bones why those things work, and also for your immune system. Vitamin D is really strong for resistance to illness and long-term illness as well as infection. So it's important to have that. And really that bone density is crucial because, you think about how often do you find, not even as you grow older, I fell in the driveway this winter, but you fall and you can crack a bone. And it's not always a fall. If you have osteoporosis and you bang your wrist on a table, you can fracture it. If I can't tell you the number of people who have told me they rolled over in bed and cracked a rib or their vertebrae because their bone density is so low. So that's something that lands a fall, and the consequences of a fall, something that lands a lot of seniors in a nursing home. And then when they're in there, they have pneumonia and then they get a blood clot. I mean, that's the thing that I really am concerned about the most. And it seems like the thing that women and even men are concerned about the least, because we can't see that. We can't see how our bones look on the inside. We can't tell how they're functioning until they aren't functioning. So that's a big topic. Well, insurance companies generally cover it at age 50 or over, but it also depends upon your risk factors. So if you're somebody maybe who's had a hysterectomy at a young age, you got a family history, you've broken a bone, whatever, that might be different for you. But for the most part, those things are like age 50 or older. Mm-hmm. The Pixie, the little Pixie one where you stick your foot in a machine or your arm in a machine. Yeah, that's like a screening. Hey, I'll take that. That's kind of, you know how it used to be, it's more refined now, but it used to be when they check your cholesterol by finger stick, it was just a total cholesterol. It was kind of a general idea. And then you went and had blood work and it was more specific. That's kind of what those are. Those peripheral tests give you a general idea. You want a DEXA if, you know, you really want to see this, the density of your bones in different places in your body. Yeah, you just lay on a machine, the thing scans over the top of you. Yeah, it's painless. It doesn't take that long, but it's very accurate. Yeah, it's a pretty gross analysis. It's just kind of gives you an idea of what your overall could be based upon some kind of mathematical equation as to how it, but what you really want to do is look at a lot of your hip bone and your vertebrae, because those are your weight bearing centers. And that's usually where somebody really develops a problem. And the wrist, you know, when you fall, a lot of people fall and catch themselves like this, and then you get that wrist fracture. If younger people, sometimes you'll hear they'll get a stress fracture in their foot. And if they're young when that happens, I always suggest that they have their bone density checked. And then no matter what, I talk to them about the diet and supplements, because I mean, it can happen in athletes, but if you're not really an athlete and you're getting stress fractures, you've got to look into why that is and if you're at risk. There are also herbal products that I will use to help women. You've probably heard a lot of them, like black cohosh or Vitex, chasteberry. Yeah, they do work. And yeah, there are clinical studies on a lot of those herbs showing that they do help with menopausal symptoms, mostly like hot flashes and night sweats and mood swings and those kinds of things. So just depending upon somebody's risk factors, what they're willing to do, you know, I will oftentimes put them on an herbal product. I particularly like blends. Like, I think Mother Nature knows what it's doing. And you'll find that a lot of these herbs work very well synergistically together. And you can use a lower dosage than just selecting one or two and taking a higher dosage of those. But you just have to work with somebody that knows what they're doing, or, you know, talk to people who use it, read a reliable text, so that you just don't go into it blind, because some of them do have contraindications. For example, black cohosh, that would be one that if you've got really high blood pressure, that might not be a good selection for you. Some of the products will have soy in them, so you have to be aware of that, because a lot, you know, soy, they'll blend that with dong quai and ginseng and black cohosh. Not saying they don't work, but that might not be the particular product somebody needs if they use thyroid medication. So yes, they do work. Do they all work? No. I mean, you see a lot of things on TV and you think, wow, that sounds really good, but you need to look behind the gimmick and see if there's any research behind that. And don't just think because it's over the counter that it's harmless. I love ashwagandha. Ashwagandha is an Ayurvedic herb supplement that is used as a tonic. It's a nice balancer. So it doesn't just have to be used for menopause. I use it in a lot of women who are kind of like really overly stressed, or just really run down, have no stamina, or who have been sick and they're trying to kind of get back into the swing of things. You use that in a cyclical fashion. So I'll put them on there for like a certain number of months and then take them off of it, wean them off of it. And then we might repeat that cycle again. So once you're on it, if you take, it's one of those things that if you take it every day for the rest of your life, your body kind of gets used to it. It doesn't really work as well. It's nice to use during menopause, especially the early stages. Remember I said, like, if somebody comes in and wants to be proactive or in there, sometimes all you have to do is use some of those tonics like ashwagandha, and then maybe a little bit of an herb that works like progesterone. Because remember we were talking about your estrogen and your progesterone? What happens when you first go through perimenopause is as your periods become erratic, it's because you're not ovulating. You're still producing enough estrogen, most women, but it's the progesterone that starts to wane first. So they might not need something that works a little bit more like an estrogen. They might balance out better with a little bit of Vitex or something that supports the progesterone fluctuation along with like the ashwagandha. Yes, like alpha lipoic acid. Mm-hmm.
I was just put my regular, I don't have neuropathy, but it is
Mm-hmm. Oh, okay, yeah.
he suggested that, like, put 600 milligrams in the morning. Still had a lot of light sometimes. So I could take it one morning and night, and it really eased that.
Mm-hmm.
And I try to do as much as I can about it. It needs to be something.
Mm-hmm. No, that's pretty safe. And I'm glad that's working for you because peripheral neuropathy is something that's very hard to treat. There are certain conditions that people will say to me, is there anything I can take for this? That's one of them. The other one is tinnitus. Like, no, I mean, I wish there was something that I knew that really worked other than like acupuncture, that can work for some people. But as far as a supplement, there are just some things we just don't know that much about. So yes, some of those things work. Not everything works. Not everything has any research behind it, but some things have like, what do you want to call it? Just tradition behind it. Like it's been used for decades or centuries by healers or naturopathic practitioners. And I think you have to give some credence to it. If it's something that's not going to be harmful, why not try it to see if it's going to be helpful?
What about the antidepressant?
Mm-hmm. That's a good segue into our last topic, which is medications. And medications can be both non-hormonal and hormonal. So we'll start with non-hormonal, and that's where you'd find your antidepressants. You'd find some of your blood pressure medicines, medicines like Neurontin that were originally used for like seizures, but are now used for chronic pain and migraines and even menopausal symptoms because of working at the level of the neurotransmitters. Yes, we first realized that antidepressants can help with like hot flashes and night sweats in studies of women who were not candidates for hormone replacement therapy.
Yeah,
so
can you like take a natural supplement? That's like regular stuff?
There are some things that you can do, yes. There are actually a lot of them. Stuff like SAMI is one, tends to be kind of expensive. One that I really like to use, and I use it very judiciously in people because sometimes you can have side effects, is one called 5-HTP. Now, it depends on which neurotransmitter I'm thinking is a little imbalanced. So for me, when I'm using 5-HTP, it's more of a serotonin low. So if somebody has a problem with their mood or fibromyalgia or irritable bowel syndrome or migraines or hot flashes and night sweats and those kinds of things, 5-HTP can work well. Or maybe insomnia, and maybe they're not responding to the melatonin. Yes, because in part, that's how antidepressants work. Now, certain antidepressants work on different, target different brain chemicals, but that is one that can work. That and the SAMI is, like I said, that one's a pretty reliable one, SAM-E. So yes, they studied the antidepressants mostly on like breast cancer survivors who were going through menopause, but weren't candidates for hormone replacement therapy, and found that they were very effective at controlling those. So there are medications that can be used if some of the natural stuff's not working for you. It doesn't work for everybody, but you don't want to go to the level of hormone replacement therapy just yet. There are some, like I said, blood pressure medications that can work. So if somebody's already got high blood pressure and they're going through menopause, that might be a good option for them. So that's why it really helps to kind of know, or at least ask your doctor, well, what other medicines are there? Because they might automatically just assume hormone replacement therapy. And there are some other ones that do work. Now, hormone replacement therapy does an excellent job of managing menopausal symptoms. I think after the Women's Health Initiative study, which was halted in 2002 prematurely, I think you know how the media runs with something and then that's what you remember, like that's what's in your mind. I think it's kind of unfortunate because then I think the benefits of hormone replacement therapy kind of got pushed to the back seat And then over time, as they continued to study women, we realized, yeah, well, maybe those risks really aren't as high as we thought, and there's a safe way to use it. All right, so with hormone replacement therapy, using it in, it doesn't really make sense to use it in a woman who's only having mild symptoms when other things can, you can use and might be more tolerable. So the bottom line for hormone replacement, whether it's estrogen and progesterone, is the lowest dose for the shortest period of time. Short-term therapy is less than 5 years. Significant risk of things like heart disease, stroke, breast cancer aren't there until over 5 years, or in much older women. Now, one of the criticisms, and I want to talk to you a little bit about that because I want you to see what the numbers were. It kind of reminds me of, was it the Johnson & Johnson vaccine that was stopped because like 6 or 8 women got blood clots out of like 8 million? I mean, it's kind of the same thing. And it kind of overrides the benefits, because the benefits include it alleviates your menopausal symptoms, it helps to preserve your bone health, it does help with your mood, it does reduce your risk of colon cancer. But the question's always been, what's it do to my breast cancer risk and even heart attack and stroke? Well, with the Women's Health Initiative, just to kind of keep this in perspective, 10,000 women on hormone replacement therapy versus 10,000 women not on hormone replacement therapy. And they had 2 arms to this study. Women with a uterus and ovaries, hysterectomized women. The hysterectomized women, that trial, that went on for 2 more years. And it was only halted because all they found were benefits. Like, it's safest, hormone replacement therapy is actually safest in women without a uterus. The arm that was halted was the part where they used women who had a uterus. And they halted it because they said, whoa, they have an increased risk for breast cancer. They have an increased risk for stroke and heart attack on this. I don't know if we should continue this study. So of the 10,000 women on hormone replacement and the 10,000 women not on hormone replacement, per year, there were 8 more cases of breast cancer in the 10,000 women on hormone replacement therapy. 8 more cases. 7 more cases of heart attack. 8 more cases of stroke. 5 to 6 fewer cases of osteoporosis, and 6 fewer cases of colon cancer. All right. That came out to a risk of breast cancer of 0.1% increase per year you're on it per person. Now, if you're a person who's at high risk for breast cancer, you may say, I don't even want that little bit of increased risk. And that would be completely appropriate. But if you're not, or you're one of those women who's tried everything and is still struggling, but you're avoiding taking, something in a small dose for a couple years to get you through the rough spot, I just think that's tragic. Because again, it goes back to your quality of life. The other criticism of this study was the average age of the woman in the study was 63. Now remember, natural menopause, 45 to 55. So maybe they weren't the appropriate candidates to initiate hormone replacement therapy. They also only used one type of estrogen and progesterone. And it wasn't a bioidentical type. What I mean by that is there are types of estrogen and progesterone and testosterone that are chemically identical to what your body produces. There are clinicians out there who will tell you it doesn't make a difference. Estrogen's estrogen, progesterone's progesterone. I don't happen to be one of those people, because I think if you can supplement your body with something that's chemically identical versus something that's foreign looking to your body, why wouldn't you? Now, I'm not saying that it doesn't carry some of these risks, but what I see with women, like anecdotally in my own experience, is they do better on it for the most part. There's a lower incidence of side effects. There are some women who, for whatever reason, metabolize bioidentical hormones too quickly and won't stay in their system. It doesn't manage their symptoms. That's the only thing I've seen in a very small handful of women. So I guess what they're saying is we didn't look at this and study this with different types of estrogen, except for in your hysterectomized women, because if you don't have a uterus and you use hormone replacement, you don't need progesterone. Progesterone is to help prevent the overgrowth in your uterus from the estrogen. So it decreases your risk of uterine cancer. If you don't have a uterus, you don't have that risk. So in women who have a uterus, when you're using hormone replacement, it's estrogen and progesterone. Testosterone if you have a problem with libido. In a hysterectomized woman, you can just use estrogen and testosterone if you need that. So there's a lot more to that hormone replacement story. Bottom line here, I'm not trying to make you a pharmacist, but what I'm trying to do is make you realize that you need to ask questions to see, well, exactly why aren't you recommending? Your doctor may have a really good reason to say, oh, because of this in your blood work or this in your history, but find out whether or not it's an option for you. So hormone replacement in women with moderate to severe symptoms, lowest dose for the shortest period of time, which short-term use is less than 5 years. You got many options available. I would try to go with the bioidenticals. And if you're not in the throes of it, if you're not feeling like, oh Lord, this is awful, start off on the end of, okay, my lifestyle, the dietary supplements and herbals, maybe some non-hormonal medication before you get there. But if you're struggling, yeah, it may be very appropriate for you to use some hormone replacement therapy and balance yourself off. No one says you have to stay on that forever. The other thing is, whether or not you go on it, revisit your decision every year. If you're in menopause and you decide to go on it or you don't, every year reevaluate your decision based upon how you're doing and how you're feeling, as well as any new information that might be out about hormones. So it is an option for women. It's not your only option, and it's not as dangerous as we sometimes believe that it is. Does it ever end? Yeah. Okay. Well, that's interesting because, yeah. 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 I don't know that they, for some women, they totally go away, but for most women, they get them periodically. It's not usually an issue. Yes. And that's usually what happens. Yes, yes. But it's usually, if it's something that's a trigger and it's something that someone does regularly, it's not going to just be periodically, it's going to be more frequent. But sometimes it's almost like a migraine. If you've ever had a migraine, you have a threshold. So you might be getting good sleep during this period. You might be, not so stressed, but maybe chocolate triggers your migraine. And you have chocolate, but hey, I didn't get a migraine when I ate chocolate this time. But the next time you go to eat chocolate, okay, you've been stressed out at work and at home, you haven't been getting any sleep, and now you eat chocolate, you get a migraine. Again, it's that threshold. What's going on with the rest of your body? And can it sustain its equilibrium? Or is that trigger going to send you over the edge? And it can be that way with hot flashes too. You can have a period of time where you're feeling like really centered and everything's, and you're eating well and you're sleeping well and your trigger doesn't bother you. And then there are other times, oh my gosh, I'm worried about this. My schedule's really busy. And then you start to have them. Mm-hmm. Mm-hmm. Sure. Mm-hmm. No, I haven't. Has that always been that way? Huh. Yeah, I mean, part of a hot flash, part of a hot flash is a circulatory component. And so I suspect there's something there, or it could trigger like a little spasm in the bladder. Yeah, but no, I've never heard of that. Yeah, I have. From the woman who's got the densest bones in Florida. Yeah.
And I do like spinach.
Mhm.
But they were saying too much spinach is not good. Have you ever heard that? Or is that right?
Yes, if you eat a huge amount of certain vegetables that are high in oxalic acid, and greens would be one of them, and I mean a lot of greens every day, and in particular if they're raw, it can interfere with the absorption of your calcium and some other minerals. I don't ever find that. Yeah, I say just cook it and eat it. Yes. Mhm. Right. And what I think is Mother Nature has a reason why she puts foods, minerals and vitamins and stuff in foods, and they work synergistically together. So, like, you read something little like that, and I'm sure somebody's really well intentioned by studying that and putting it in there, but how practical is that on a daily basis? How applicable is that? To me, it just scares people away from eating their vegetables. Or if you have a blood clotting disorder. She has what? Yes, if you have a blood clotting disorder. But again, what I tell people with that is don't avoid those foods, but eat them in the same amounts on a regular basis so that when they get your blood work, you're comparing apples to apples. So it's more about consistency. They can adjust your medication dosage based upon what you do on a consistent basis.
And that's, we've heard it.
Yeah.
We always have to be careful about finding too many ingredients before she goes.
Yeah, that's right.
We're careful about, oh, I can't ask finish there.
Yeah.
When they get leveled out.
Yes, but you have to, yes, you just have to, it's got to be regularity. And I think there's a lot to your body and that blood clotting that we don't know. Because people can do everything right. And I know people who go in and they constantly have to have their medication dosage changed because it's different every time. And then you see seasonal changes. So there's something with the temperature. Like, I just think there's a lot there we're not really sure of.
I heard that people that are on blood thinners, they can't take turmeric or something like that.
Yeah, there are schools of thought, and blood thinners, again, I don't think we know all there is to know about them, that there are some herbal products that can result in changes in your blood titers. Some of those herbal products and some of those roots that you're talking about, they call blood thinners, but do they actually thin your blood? Like, do they actually change the level of platelets in your coagulation time in your blood? Sometimes those recommendations are theoretical risk. Like, we think, okay, if this compound works this way with blood clotting, and this food has these components, and technically that could affect blood clotting, therefore we shouldn't mix these two. But it's based on a theoretical risk rather than a practical risk. So I think people do recommend that out of an abundance of caution and not wanting to cause a problem on something we're not really sure about. So again, what I tell them is it's consistency with your nutrition. Make sure you're telling your doctor what you're eating and that you're getting about the same amount in this, a week. It doesn't have to be on a particular day. So that when they get your blood work, they know that everything's pretty much the same, and then they can make those changes according to that. And I hardly ever, I've never honestly seen anybody who's eaten so much turmeric or spinach, that it's become detrimental to their blood work. Yeah. Yeah.
I remember when I taught myself, when I took turmeric every day, there was just a little cut, and I looked up on the internet, it said to be like a blood thinner. I noticed when I did start taking it, my blood count, and kind of.
Yeah, I'm not